Hi, and welcome to Interprofessional Conversations, where we elevate your health and wellness through sharing knowledge. Thanks so much for joining us. I'm your co-host, Chris Foreman, along with Dr. Giancarlo Licata. Today's guest is Jay Gunkelman. Jay is a leading brain specialist who has a wealth of knowledge and decades of experience. In fact, he has reviewed over 500,000 brain maps. Jay's involvement in applied psychophysiology and biofeedback dates back to 1972. And since the mid-1970s, he's specialized in clinical EEG, making Jay one of the most experienced EEG specialists in the world. This is part 2 of our conversation. In this episode, Jay unpacks the role of qEEG for functional medicine, marriage and family therapists, and other mental health practices. He also answers some of your questions on topics such as sleep deprivation and its effect on the brain. It's a great episode with lots of practical insights to use in your practice. This episode is best experienced on our YouTube channel, so if you're listening on an audio platform, check the show notes for a link to the video. Without further ado, here's part 2 of our conversation with Jay Gunkelman.
If we circle back to COVID and, I'm trying to now think about scenarios where, a practitioner, a functional medicine doctor. I had a conversation with a functional medicine colleague. She came to the office and we chatted for at least a good hour. And this is what she said her problem was. She said, look, my practice is filled with people that are either going through recovery from COVID or have long hauler syndrome. And I don't have a gauge to understand what is the underlying mechanism so that I can then create a process for healing, right? So this is what started some of my discovery and what ultimately led me to you, Jay, which what I appreciate, and that's why we're having this conversation. So, as a purely quote unquote assessment or diagnostic tool, first, we can talk about what role we may have, other neurofeedback people can have, but how can this help her? How can this help our acupuncture and oriental medicine practitioners? How can this help our marriage family therapists and psychologists? Help give some flesh to this.
Sure. If the psychologist is also doing neurofeedback, they have a treatment approach that matches up really well with this assessment technique.
Right.
The assessment technique can actually give you objective evidence of where the problem is, and potentially how to treat it. The neuromodulatory treatments, including, there's some people that actually need to have a pharma intervention, not just neurofeedback as well. As an example of that, we could look at the patient who's agitated with paranoia as their post-COVID, and take a look at that.
Right, let's do it. That'd be great. Yeah, because I want to make this as useful as possible, not just to tout the benefits of neurofeedback, which obviously I'm biased and so are you, and we think that it can be a profound targeted approach. But what about for practitioners who just want more insight and maybe they want to rely on their own tools to begin with?
Sure.
Right.
Sure.
Like how can we help them get more insight so they can target their own tools even a little bit better, right? And so whether it's pharma or herbs or functional medicine, right? Okay, great.
If you can see the pathology, you can name the pathology. Basically, there it is. And you validate your patient's complaint, which is kind of a little less than easily diagnosable in most medical evaluations. I have long hauler brain fog. Well, where does the doctor stick something to find that? I mean, first of all, you have to show what system in the brain is quote foggy, and in this particular patient, for instance, this is an eyes open EEG, and we don't really have any normal rhythmic background alpha. If you look at the rhythm that you see here, 1, 2, 3 plus, that's over 15 cycles a second. That's beta, that's not alpha. So what do we have? We've got somebody who's grossly over aroused to the point where they're not making background alpha. And this person's EEG eyes open has no real resting state alpha. It has beta in it, but no resting state alpha. Now, beta spindling like this that's widespread is one of the things you can see in psychosis. This patient is post-COVID agitated and paranoia. So the beta spindle here is cortical hyperexcitability. At rest with their eyes open, they're not relaxed enough to make a resting state EEG rhythm of any sort. So let me close out the eyes open on this one. And we're going to pop into the eyes closed where the background alpha normally shows up. We have alpha and we have intermixed beta. And you can see the alpha, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, almost 12 hertz. So it's the fast kind of alpha, not at 7, 8, but this is cranked up very fast. So this EEG has some artifacts that are still in it. It's not all cleaned up like the first one we showed, but with their eyes closed, this person has very little eye movement. You can see some subtle eye movement, vertical, and probably some lateral
Nobody's
as well.
going to see that, Jay. Nobody can tell what the heck those squiggly lines are.
Well, there's an eye movement for you.
There you go.
That's actually an eye blink. Yeah. But right after that eye movement, we get this person's background rhythm is as well formed as it is anywhere in the EEG. And again, starting on the line 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 plus.
Yeah.
So I'm going to leave the artifacts in and just get the spectra for this. You're going to end up seeing both the beta and the alpha peaks. Fill by band range. Alpha should be in the yellow. The peak of the alpha is right at the 12, 13 border. It's normally way fast. I mean, this is abnormally fast for alpha. Some people have way fast alpha because they're extremely bright, but they're over aroused and usually have problems with over arousal, like insomnia, anxiety, that sort of thing. So this is very, very fast alpha, but it's still alpha. And when you map it, you should get alpha at the back of the head. Well, what's this? There's an alpha peak over here where it shouldn't be. This is emotional comprehension, facial expressions, body language, and that area is idled out. So even though it's fast alpha, it's an idled state in an area that we don't normally expect. I expect alpha at 01, 02 PZ. I expect the alpha peak to drop down or drop out by the time you get to the temporal. It goes up to get here. So there's too much alpha here. And remember that 15 that we counted? That 15, 16, 17, 18, the beta spindling. And the beta spindling is something that is identified in psychosis. The beta spindling here is a hyperexcitable cortex. And this patient ends up having beta spindles and fast alpha, two forms of overarousal. Fast alpha is a thalamocortical overarousal. Beta spindles are a cortical overarousal. So this person has both kinds of overarousal. And when you're overaroused to this extent, you can expect symptoms. And this person ends up being anxious, overaroused, and obviously the fast alpha and beta spindles are the deviation that they're left with as a post-COVID finding. Now, if you're anoxic, not totally hypoxic, but anoxic for a period of time, and how can you get that way? Well, COVID. I mean,
Yeah.
you're breathing as fast as you can. Your blood saturation drops down to the 90 range. They haven't quite flopped you over to a ventilator, but you're not really pulling in as much oxygen as you should have. You end up with increased glutamate. It's excitatory neurochemistry.
Mhm.
And we've got fast alpha and beta spindles that can be accentuated from glutamate. The hypothetical source of this person's problem is post-COVID, you know, dysfunction, basically from overarousal from too long a period. Now, the beta spindles can be reduced from a number of things. You can reduce them with channel blockers like Intuitive 10x, clonidine, the usually blood pressure medication used off-label to reduce beta spindling in the EEG. Like you see sometimes in an ADD case, the rare ADD cases, beta spindles in it. UCLA published a very nice study. Sandra Liu published it, and it showed if you had theta, you needed Ritalin, but if you had beta spindles, needed guanfacine, which is Intuitive 10x brand names for guanfacine. And if you had both, you needed both medications, the theta and the beta. You end up with both of those medications effectively. That was published in 2017. A very well done academic paper. So what we see here is somebody that could respond pharmacologically to stripping away excitatory neurochemistry with a channel blocker. Antipsychotics reduce beta, but they can also increase paroxysm. So if the EEG had bursty activity, the antipsychotic could actually make some things worse. And anticonvulsants used as a stabilizing agent in psychiatry, like Lamictal, it's a glutamate modulator, and it'll reduce this as well. So there's a number of pharma ways to reduce this, but neurofeedback can reduce the beta by directly training it in an operant way. It can slow down the alpha by training regular 8 to 10 hertz alpha at PZ and suppressing the faster activity. So there's ways to operantly train this brain to behave better.
Yeah, and I remember having a conversation with, again, another functional medicine practitioner who mentioned, sometimes, high doses of omega-3 oils can be useful because they act as, one, a blood thinner because they reduce COX-2 inhibitory or inflammatory pathways, and because they cross the blood-brain barrier, they can, oftentimes act as just a general antioxidant inside the brain itself, right?
Yep.
And so, and other people have talked about magnesium, high dose magnesium and magnesium threonates specifically, because that also seems to have a higher absorption rate, and the magnesium will tend to kind of also it raises the threshold, so there's lower activity. Is that but the whole idea is that if we can understand a little bit more nuance of the underlying mechanism, then, these different practitioners can begin to, cater their tools a little bit better. Right?
Yeah, exactly. If you see there's the hyperexcitable beta, you have tools that can end up winding it down.
Yeah.
If you don't see it, what are we looking at? The same paranoid psychosis stuff can be generated by epileptiform discharges coming out of the insula.
Yeah.
So, what do we see? Well, we don't see big bursts coming out of the insula. We see beta spindles, which account for the person's, paranoia and agitation. So if I was a cardiologist and you came to me and said, Doc, I've got this chest pain, and I operated like psychology and psychiatry do, I would take you straight to angioplasty, and half the people getting angioplasty would have just had indigestion. The complaint doesn't tell you how to fix them. It tells you should do testing. And if your complaint is about a cognitive disturbance, you should do the EEG testing. At that point, the complaint ends up having a biomarker. The biomarker will tell you, that's just indigestion. It's not in need of a cardiac fix. So in this case, beta spindles overarousal, fast alpha, you see two kinds of overarousal you could deal with. If you didn't look, we wouldn't know. It could be big bursts coming out of the insula causing the psychosis just as easily.
Right.
So the symptom, doc, I got paranoia, just like doc, I got this chest pain, the symptom tells you need to do a study of some sort to test the clinical assumption. You could have the assumption, oh, it's epileptiform content in the insula. And if you look and don't see that, you've got to come up with a different assumption. You can't treat it that way.
Yeah,
So
this is so fantastic, and it may be, we can continue down this line of conversation because it is such a big fundamental part of our interprofessional model, right? It's this understanding that as a practitioner, I'm seeing through a lens, and it's not the only lens that exists, right?
yeah,
And so, but also I can try to say I want to be integrative and holistic, and which then all of a sudden I usually go to the other extreme and I say I am going to be everything for you. I'm going to be your medical doctor, your therapist. I'm going to be your nutritionist and your trainer. And but then of course I can't do all those things myself either. And so as a practitioner, how do I kind of get good at my lens, at what I'm good at, but how can I begin to see that there may be other things? This client may need other people on their team. So how do I better understand who the ad hoc team should be for this client in this period of time, right?
If you're going to commonly run into people that have neurocognitive complaints, attentional or affective disturbances, sensory processing problems, dementias, those kind of things, you're going to end up needing to take a look at brain function at some point. Yeah. If you're not the person that looks at the EEG yourself, at least become the person that can get the EEG recorded somehow, either in your office or by a simple referral. It's, it takes less than an hour, a little bit of time to hook them up, 20 minutes of recording time, 10 minutes eyes open, 10 minutes eyes closed, and a little bit of time to clean them up and send them on their way. But, an hour later, your office space is freed up for something else. And it's not like the EEG devices of the past where they were, my first qEEG device was $165,000 a piece. I had to get 4 of them for the lab. Now you can get the same, you get better technology than that. Now for about 10 grand a piece, you get the amplifier and software to end up doing all that analysis. So, the cost has come down to a manageable level. But again, if you're not geared up for doing the EEG yourself, get somebody that is geared up for it to do the recordings for you. You can end up with a consultation with somebody or a professional report provided for you. There's a number of services out there that provide that. And at that point, you've got data that actually shows you, it wasn't that it was just indigestion on this case. It wasn't really a cardiac problem. You have to look with the lab test to end up differentiating which guess was right, if which one of your clinical guesses would have been right. So again, team up. You can't do it all. I mean, what are we going to do? Hire octopuses? I mean, eight arms. You can work a little better with 8 arms.
As practitioners, we feel like that sometimes, right? We feel like we're trying to just put out everybody's fire and put out every fire that each person has, right? So it can be very overwhelming, especially now when there's with COVID. I mean, I work with so many mental health professionals, and I have just so much respect for them and what they do and how they've really shaped the way that I view health over the last few years working with them. But, at this point now, oftentimes they're swamped. They're swamped. I mean, it's whether it's lockdowns or, family members that are sick or fear, or I can't go to prom, or, there's a million external causes for these mental health challenges. But now I think what I wanted this conversation to at least shed light on is that there can be internal chemical changes that are going on, where if you just try to help somebody cope with not going to prom, but they're going into full panic attacks, maybe there's a physiological aspect to that person that you don't want to ignore, right? At least don't ignore it,
Yeah. Anxiety doesn't have a direct specific epileptiform correlate. There's no discharge in the EEG that causes anxiety. Panic attack, on the other hand, about a third of the time, people that have severe panic attacks actually have epileptiform or paroxysmal activity in the EEG that needs to be stabilized. There was a very nice a study that was done 2020. Martijn Arns is one of the primary researchers. They looked at people that had epileptiform discharges in the EEG that were non-epileptic. And they had 700 and something cases of people like this. And they went through and analyzed literature searches and found that, epileptiform content happens a lot in psychiatric disturbances, panic, attentional problems. 20-something% of the ADD population actually have underlying epileptiform discharges that are undiagnosed generally. Unless you look at the EEG, you don't see it. Unless you're having a convulsion, the neurologist isn't going to prescribe an anticonvulsant for you. However, we've actually made recommendations for people to treat the psychiatric patient who has epileptiform discharges with an anti-epileptic medication, an anticonvulsant. And, if you go to a neurologist and say, "Doc, look at this abnormal EEG, there's an epileptiform burst," they'll say, "Well, if the patient is not having a seizure, we don't treat the EEG, we treat the patient." And, unless you're having a convulsion of some sort, they won't give you an anticonvulsant. Psychiatrist, on the other hand, uses anticonvulsants as a stabilizing agent. They don't want to treat epilepsy. They're a psychiatrist, not a neurologist. But if you have an epileptiform discharge and a psychiatric presentation, we've shown, based on our recommendation, the doctor followed the recommendation. They actually treated the person that had the epileptiform content, not for epilepsy, but for their psychiatric disturbance. 85% of the cases had an improvement. 85%. And it wasn't a small N. There's a fairly substantial N.
Yeah.
So,
and by N, just for some of those listening, an N is the sample size. How many people were in the study?
Yeah, exactly. Yeah. Our publication back in 2017 had an N of 76, if I'm not mistaken, cases that were treated with an anticonvulsant. All but 5 of them ended up getting better, 85% improvement. Of the 5 that didn't get better, 3 of them basically had a reaction to the anticonvulsant, a rash or a fever, and they had to stop it. So those were characterized as not a success, but a failure. So part of the failure was just that they couldn't take the medication.
Right.
So,
and that's wonderful. And so, and again, it goes, if you understand the mechanism, then you can use the tool that you're good with. You work with, right, Jay, correct me if I'm wrong, but you've classically worked with psychiatrists, neurologists, people that work with medication, right? I mean, that's your field. Because I work with so many other health professionals in other kind of fields, we know that neurofeedback can be a phenomenal tool to regulate and normalize paroxysmal bursts. Is that correct?
Absolutely.
Right. So there's another tool that if somebody didn't have medication as their main tool set, they can do that. And I also understand that both Oriental medicine and a lot of functional medicine, including some of the cannabis work and some of the keto studies that are out there for nutritionists, that there are ways to also, raise the threshold for that kindling for some of those paroxysmal bursts, so those happen less as well. So again, different tools. But if you can understand the mechanism, then you can use the best set of tools at your disposal, right?
Yes. And for epilepsy, a third of all epileptics are intractable epileptics. There's no benefit for the medications that they're receiving. They're candidates for potentially surgical interventions at that point, for brain surgery to try and cut out a spot that might be causing things. Yeah. But, if you look at intractable epilepsy, not the 1/3 that are well treated or easily treated with an anticonvulsant medication, or the 1/3 that might have some benefit but not full benefit, we're talking about the 1/3 that are intractable. If you restrict it to intractable epilepsy, the brain surgery at 3-year follow-up has a 50% chance of a 50% or greater reduction in seizures. Now, it doesn't sound like a really good deal. but if you give somebody a half a chance of getting rid of their epilepsy, they're going to take it.
They're going to take it. They're going to take it. Yeah.
Because it can be really horrible. Intractable epileptics with neurofeedback, there's a meta-analysis done by Gabriel Tan. There was another one repeated more currently, but Gabriel Tan's evaluation showed just about an 80% success rate.
Wow.
Again, using the 50% or greater reduction in seizures as a success rate. Yeah. Now, I have an N of 6, which isn't a big N. I mean, 6 patients in a row. It's a case series, not a study. There's no control group. Yeah. But these were intractable epileptics that were having hundreds of seizures a day.
Yeah.
And no benefit from meds. All 6 of them are at this point medication-free and seizure-free.
Yeah. Yeah.
And for 4 years, the youngest one that's now seizure-free for 4 years. Yeah. So we've one of them was written up in Israel, where the little girl lived. She couldn't speak. She was 8 years old, couldn't speak, couldn't tie her shoes. And we usually quote over 100 sessions of training. Hers was 42 training sessions. It was really quite fast. I mean, way faster than we expected. But she was riding a bicycle and speaking fluently 42 training sessions later.
Wow.
We're writing one up now. Rusty Turner is a epileptologist, child neurologist, and he was involved in the case. We're writing up a case from Barcelona. She's now a tennis Division I tennis player here in the United States with a full ride tennis scholarship. And again, she couldn't even do simple self-care, much less practice tennis. Yeah. So, you know, Maggie, a little case up in Michigan, she's been seizure-free and medication-free for 4 years, and her family agreed to have, well, they were eager to have a video documentary shot about her recovery. Basically, they showed up at a meeting and had the entire family introduced. When I talked about you should expect the unexpected, because 20% of the ADD population have unexpected epileptiform discharges. Depression, again, percentage is there. Autism, 40 to 60% of the autism population have epileptiform or paroxysmal discharges. Mm-hmm. Mm-hmm. So
yeah, we're seeing that in our office very, very commonly.
Yeah. If you don't look, you won't know.
Yeah.
And in autism, if you see an epileptiform discharge, you might consider an anticonvulsant medication to help stabilize that.
Yeah.
Now, I've got a client in Washington State where the parents sued for parity, so the insurance companies had to spend up to $500,000 a year for therapy for the autistic kids. Well, the insurance companies got the legislature to say, okay, if they have to spend that kind of money, you have to have your kid diagnosed at a center of excellence, and they had like 6 or 7 of these centers in the state. Well, one of my clients is a center of excellence, and they applied to get insurance to cover an EEG, qEEG evaluation, and they were denied. And they repetitioned a couple of times, and after a couple of years of repetitioning, the case manager said, "Well, what the heck? I've spent $500,000 a year for 2 years. Go ahead and do your testing. We'll see if you can get some benefit." And we see an epileptiform discharge. Recommend an anticonvulsant medication in the report. They refer to a local epileptologist who then medicates the kid, and the quote autism fades away because the epileptiform discharges were disturbing the area that was needed to function, and when it was gone, the function returned. So, you know, it's important to end up focusing on what the underlying pathophysiology is, not just the diagnosis.
Yes.
Yeah, being on the autism spectrum doesn't tell you how to fix them; it just tells you how to bill for it.
Right. So. Right. No, so useful, so helpful. You know, what we're going to do is probably close this conversation up. If there's anything else you'd like to continue to explore, we can. And then we have a few questions from the community. So
Sure.
along this, let's say there's a group of interprofessionals that are starting to look outside of their own box to better understand their client, especially now within the context of COVID. They have clients that are dealing with these challenges, whether it's, long haulers, brain fog, depression, anxiety, or all these new, just hard ways to deal with life. Or, like you're saying, they weren't even diagnosed with COVID. They don't even know they had it, right?
Yeah.
Is there a role for an EEG or a qEEG that could be used just as diagnostic? Let them do all the tools they want. We do it in our center, so I don't want to self-promote, but we're here in Pasadena. You're retired, but your place does it remotely as well. Is that correct? Meaning they can, so they can
Yeah.
get it done and then send it for interpretation. Is that correct?
Yes, that's correct. And there's quantitative EEG certification boards. You can go there and find, according to where they're located, somebody that's competent near you for the qEEG evaluation or EEG evaluation. There's a lot of people nationwide at this point that can end up doing this kind of an evaluation. Once the EEG is recorded, we then process it. Once we process it into maps and everything, it can be analyzed and interpreted. There's a lot of commercial services that will do that for you on a turnkey. Send them the data, they'll turn it around, give you the report back. They're actually pretty darn good nowadays. There was a day in the past that it would have been kind of iffy making just a general recommendation to the ones that are available as commercial services. But at this point, most of them have shaken out. The good ones are left. Yeah. And if you don't look at the EEG and your client has a cognitive or emotional disturbance of some sort, you're not looking at the organ that you're trying to treat.
Yeah.
And quite honestly, it shocks me that psychiatry hasn't kind of glommed onto this whole biomarker thing when the DSM was given the pejorative that it wasn't valid. It was highly reliable. You get the same exact DSM category again and again and again, but it doesn't tell you what to treat. I mean, if there's no way to know how to treat, there's really not an intervention that falls out from the data set. But if you actually look at the EEG, qEEG, normally the treatment falls directly from that. You'll see what the pathophysiology is, what kind of biomarker sits in front of you, and for every biomarker pattern, there's a way to play that hand.
Yeah. No, that's fantastic. And now, what are some of the failure points in other neurofeedback centers or EEG centers? Like, how can somebody be critically minded so that they don't refer a client out and say, "Oh, well, they do that." What's kind of minimum level competency that we want to be aware of?
Again, people that have passed the minimum standards have shown at least the due diligence of going through the didactic coursework and passing a test and all of that. It's not like the tests are impossible to pass, because a lot of people pass them, but they do establish kind of a benchmark minimum standard for what the person should know. For neurofeedback purposes, BCIA used to be a Biofeedback Certification Institute of America, but it's now Biofeedback Certification International Alliance. They certify people all over the world for being competent in neurofeedback and biofeedback and forms of biofeedback like pelvic floor treatment and heart rate variability. So there's a lot of different certifications that they provide. BCIA.org will end up having a website that can end up finding you a neurofeedback or biofeedback practitioner or HRV practitioner in your area that's been shown to be competent in that application. And as a basic level of competence, I think BCIA is internationally accepted, and it's not a self-certifying membership organization. You don't join BCIA and get your certificate.
Yeah.
This is actually a testing body that goes through periodically redoing their testing. They have multiple forms of the exam, so people don't, take some, Google Glass snapshot of the exam and have the ability to tell people the answer to number 13 is D or something, So a professional testing organization with professional standards and controls over who handles the exams. Anyway, I think that's one very basic.
That's great.
If you know a particular brand of equipment that somebody is using, normally there's certifications for manufacturers that will certify them as competent in operating the equipment, but it doesn't certify them as being competent within the area of clinical application. BCIA is the one that does that.
Yeah, that's great. That's helpful. And there's also the qEEG diplomate that's in the reading of the EEGs, and the BCIAs is the actual neurofeedback training side of it, correct? Right. Yeah. And for anybody, so I've basically completed all the coursework and mentorship. I need to take my test. So just if you look on it, you're not going to see me yet, but there's that. Okay, so with that, a couple quick questions. Somebody was asking, what does lack of sleep look like in an EEG? How will people? That's been a big sleep. Sleep is finally crossing the threshold of, oh, this stuff is important. This stuff is important. So what does it look? What does it look like?
Well, let's take a quick look at actually some data.
All right.
Let's pop open somebody that's got a sleep problem.
And if you can describe it for some of the people, because probably a big group of our listeners won't see it. So
okay,
just as
we start out with the person here with the eyes closed, and with the eyes closed, we have alpha in the back of the head. Now, in Europe, there's a group that has looked at the eyes closed EEG and how the eyes closed EEG relates to being vigilant. Vigilant being a way to show that you can actually interact appropriately with the external world. So if you've got alpha in the back of your head, you're basically awake. If the alpha start to show up front, you're less vigilant, but you're still awake. If the alpha becomes really prominent up front, bigger than the alpha in the back of the head, you're even less vigilant, and you're right next to being ready to doze off. The next step is alpha dropout. And with the alpha big in the back of the head is a state called A1. A2 alphas in the front, alpha prominent up front and not in the back is A3. So it goes from A1 to A3. B1 is the next stage. And at that point, alpha quits. It just drops right out. And the next stage after that is B2. Theta start to happen up front. Then B3, theta's big up front. The next stage is the first stage of sleep. Now, stage 1 sleep is drowsiness. It's not really sleep, but it's stage 1. And stage 1 is usually the alpha dropout and theta starting to happen. But it's not a vertex sharp wave. And a vertex sharp wave is stage 2 sleep, when you're starting to actually doze off. Now, as I start to scroll through this raw EEG, we're going to go from awake through the drowsy stages and hit the stage 2 vertex sharp wave. We start out here with alpha in the back of the head. You can see the waveform of alpha, again, 8 to 10 of these wiggly lines in a second, and it's pretty good sized and fairly well organized at the back of the head. But there's some of it that's starting to show up front. As we continue to scroll into the EEG, you can see times where the alpha up front is actually well organized and the alpha in the back fell apart. So we're getting into the B2, B3 stage. If we continue scrolling, you can see alpha has dropped out for a moment. It returned for a moment, but then it dropped out again. And now theta is starting to happen. So B1 to B3, maybe somewhere in that range, but they wake up again, alpha dominant in the back, not up front. So in the first 30 seconds, they've gone from awake to lightly drowsy and back to awake, and then to lightly, and then a little deeper drowsy, and then back awake. So this is called labile vigilance regulation. And when you're sleep deprived or you have a sleep disorder, you end up having labile vigilance regulation. So he's back to an alpha state. The alpha's sputtering, back to an alpha state. You can see a really distinct alpha dropout here, but back to alpha again. So labile vigilance regulation. We're only 40 something seconds in, and he's already been in and out of light drowsing. Now you'll see that the alpha sputtered and pretty well quit. And this is a long stretch of it being gone. So we've progressed from labile vigilance regulation to the person being in a stage 1 drowsiness. Now they pop back eventually here. They're, quite a few seconds worth of being dozy, but they pop back again. So they're going in and out of drowsing. You can see that the drowsing, the alpha dropout is lasting longer and longer. Now this is actually a vertex wave, but it doesn't quite qualify as a vertex sharp wave. Now, people that look at the screen image will look at it and go, well, of course it's not a vertex sharp wave, it doesn't look sharp. But in a sleep lab, they don't use the same sweep speed. Let me shift you to sleep lab land. The same spot is marked by yellow. You can see why at CZ it's called the vertex sharp wave.
Yeah.
Now, this one wouldn't usually be called by a sleep lab because it's just not that impressive. They wait for one to reach up and grab them by the tie and pull their nose down to the paper. Now to the computer screen. I'm
right.
Old enough.
It's been a long time since they've been using paper, but yes.
Yeah. Well, we used to have to kill trees to do EEGs, but that's a vertex wave, but and you can see they're gone. This is stage 1. There's no real background alpha. There's a little touch of it in the temporal area, but they're gone. There's a little sputter of alpha again, but they're gone.
And now, you said you said stage 1. Once you get the vertex sharp, are they now starting to get into stage 2?
Stage 2 is a vertex sharp wave. Yeah. Now again, this is vertex activity of stage 1, and they re-alerted. What's a vertex wave? Well, a vertex wave is the brain's response to a stimulus. Now it's eyes closed. Quite commonly, it's an auditory stimulus, but it's still a response to a stimulus. Now, the vertex wave is going to end up getting really big and dramatic. There it is. Now, a sleep lab will call this one. This is the first one that they would have called. So they're in stage 2 sleep, 121 seconds in. Now, if you take somebody to a sleep lab and say, this person's not sleeping very well, I want you to do a sleep study. They'll say, well, we don't get paid always for a sleep study. We can get a screening study approved for them. And if they fail the screening, then we can do a sleep study. Well, the MSLT, multiple sleep latency test, is an afternoon nap. You go in, they hook up your EEG, and they tell you to go lay down and take a nap. Now, if you've got a sleep disorder, if they point to somewhere to go lay down and you lay down, you'll be asleep really quick. But if you have insomnia, you say, well, I can't sleep. I'm in a lab. I'm not at home. No. Well, they don't get paid for treating and testing insomnia. So if you don't fall asleep too fast in the afternoon, they can't even do a study on you. But what happens is they look for a vertex wave like this before 5 minutes, and they give you 5 naps, and they'll wake you up after you've fallen asleep. So here, the patient has fallen asleep in 2 minutes. Well, they would have failed this segment of an MSLT and waken them back up and told them to go back to sleep again. Well, I will pretty well guarantee this one is going to end up going back to sleep again and again and again. As we proceed into the EEG here, you get vertex waves, and repetitive vertex waves quite commonly end up happening. But the patient is basically, gone. Here's a vertex wave that wakes them up. Again, a response to a stimulus. If you have a really good sleep spindle, the stimulus won't wake you up. If you don't have a good sleep spindle, every time a vertex wave happens, it'll pop you back awake.
Now, so we're in stage two. How does that correlate for some of our listeners to when, usually they talk about REM sleep and deep sleep and
Sure.
light sleep. Where are we falling?
Sure. I will do some really bad art on screen.
All right.
You start out awake, then you drop to stage one, then you drop to stage two. Normally, if a vertex sharp wave doesn't wake you up, you drop to stage 3, 4, which is slow wave sleep. They used to differentiate 3 and 4. There's no reason to. They've combined them now as slow wave sleep. At that point, you might pop back up and cycle back down again. But at some point, you're going to pop up to REM. The first half of the night, you have more slow wave sleep. The last half of the night, you have more REM sleep. But you cycle through about every 90 minutes or so, you'll make another sleep cycle back through from awake to asleep, and then maybe some REM. And again, you cycle repeatedly through the night. So REM is what people consider dreaming. Stage 3 or 4 is slow wave sleep. You need slow wave sleep to become restfully recovered from the wear and tear of the day. This is where you produce growth hormone and you grow dendritic spines. So if you've learned something, you're going to grow a connection. Now, the connection isn't enough to make it a long-term thing that you've learned. You have to play your memory back with REM. So if you've grown a connection with slow wave sleep, now you'll play back memory. Short-term recall needs to be potentiated into long-term recall. And that happens during REM. And during REM, you literally play back experiences you had during the day and long-term potentiate them. I used to wait about 2 weeks after we got a new tech into the EEG lab, and I'd ask them, are you having your EEG dreams yet? And they would, if they were a good tech, they were consolidating memory about waveforms. They've learned a waveform. And how do you know what that waveform is? Well, how do you know who your grandma is? You've looked at her 1,000 different ways over the years, and you can tell it's your grandma if it's only the left half of her face or the right half of her face, or you might even be able to tell it's her from behind.
Which is similar to language, right? I mean, when I lived in Spain, that was one of the big things we realized is, the fluency is really coming because I'm now dreaming in Spanish, right?
Correct.
And that's a similar thing. Yep.
Correct. Yep. What you've learned is being encoded into long-term potentiation. Now, when you ask a tech, are you having EEG dreams? They look at you and go, oh my God, you're in my dreams, So, it's not always a great response, but the ones who are really learning it will go slack-jawed and said, how do you know I was dreaming this? Well, because you're learning it. I mean, how else are you going to learn it? You have to have it in your dreams.
Yes.
So you literally are going to have a specific waveform, a spike in wave of epilepsy, or a vertex sharp wave of sleep, or a triphasic wave of toxicity, or lambda waves in the back of your head associated with visual processing. But those patterns are being encoded and learned, and they're played back during REM. During dreams. So you grow the new connections during the slow wave sleep. You play back the patterns that you're learning during REM, and you cycle repeatedly through the night. And, for those that have insomnia, you go from awake to stage 1. You might bump into stage 2, but if you don't have a good sleep spindle, every time you have a vertex wave, you're going to pop back up to an awake state again. So you're going to have sleep onset problems. And once you do fall asleep and you cycle back up through stage 2, you're going to wake up again. So a sleep spindle is essential for good sleep. And you can train.
Those are falling in, and those are in stage 2?
Stage 2 is a vertex sharp wave with a sleep spindle.
Correct.
The sleep spindle is what keeps you from waking up when there's a vertex sharp wave. So if you have a good sleep spindle, you're going to fall asleep better, and you're going to stay asleep better. Sleep onset insomnia, wakefulness insomnia. And basically with frequent insomnia problems, we usually end up seeing beta spindles at CZ. See this little tiny beta spindle? Let me get my bad artwork out of the way here for a moment. And let me get that out of the way. Turn up the sensitivity. You can see the little fast buzz at CZ. That CZ beta spindle is what you generally see in somebody who has insomnia. Now, this person has disordered sleep, and you can see the vertex waves going by. But if you look closely, there's also fast activity here centrally. 1, 2, 3.5. This is about 18 hertz. So sleep spindles counterbalance the beta that you see centrally. The beta at CZ is a wakefulness drive. Look at the vertex waves there.
Yeah.
And a sleep spindle is the same thing as SMR.
Yeah.
Sensory motor rhythm is something we train to counterbalance in epilepsy, to stop you from having seizures. It's a stabilizing rhythm that we can train. And at night, the same exact rhythm generated by the same exact nuclear body with a little bit of a different projection pathway, because sleep opens up a frontal pathway for projection. But we see the SMR content at the vertex is a sleep spindle at night. Same exact thing.
Right. Somewhere roughly around 12 to 15 hertz.
12 to 15 hertz.
Yep.
And a classic sleep spindle, if you go to the EEG literature, they'll say it's 12 to 14. Well, actually, Barry's original SMR said 11 to 19, but group average is at 13.
Okay. Yeah.
But
so
with a really high
moving.
arousal level, it can be a little faster. With a low arousal level, it can be a little slower.
Right.
But your sleep spindle is actually set early in life. You're actually good at sleeping at 1 year old. And at 1 year old, you actually have a good sleep spindle. It's tuned to your adult tuning. It doesn't mature up like
change,
alpha does. Mu, which is an alpha-like rhythm at C3, C4, is sometimes confused with SMR. But mu is an alpha-related rhythm. It comes up to speed like alpha does.
Yeah.
So
yeah, and that's what's fascinating, and that's something that we saw in our office. There's the physiology of sleep we're seeing is so important for everything in mental health, to diabetes prevention, to longevity, to Alzheimer's, prevention with different types of, we can geek out on the glymphatic system and delta waves and all that, but what's so great is that we can see signs of poor sleep, as well as there are things that can be done. There are things that can be done to, again, same principle. Once we understand the mechanism, there's tools out there to change the individual issue, right? Now, I'm sorry to interrupt you, but we're coming close. There was one more question that I want to hopefully hit before we have to let you go here. But this comes from somebody who does depth psychoanalysis. So I don't even know necessarily what that is, but they'd love to know more about the parts of the brain that are affected by depth psychoanalysis. So if you don't recognize it, then I think we're gonna have to punt on this one. But they clarified, I'd love to know more about it. A goal of my therapeutic work is to help unconscious material come into awareness so my clients can better understand why they do what they do. What does this look like on a neuro level?
Sure. Great question. Not an easy question, but I love tough questions. I've been around forever. What good is it being around forever unless you can answer the tough questions,
Yeah.
So years ago, I had a dear friend who's passed, unfortunately, Anna Wise. And Anna didn't really know classical EEG, but she was trained really well by Maxwell Cade in England. And she's written a couple of books about the peak performing brain. And she basically had an approach. Let me stop this screen sharing and go to a whiteboard screen sharing here. They had a display that had LED bars that would go off to the side. And when activity happened from very low frequencies to very fast frequencies, you'd see a row of LEDs light up. And what she was trying to find is a pattern that they found in their advanced people, where they would have some fast activity, some alpha, some theta, and some delta. And if there was a proper mix, then their theory was that information could flow from the unconscious, preconscious, into the conscious alpha and beta rhythms. So if this frequency dipped in and didn't have any content, you'd have to fill that in to allow information flow to occur from unconscious to preconscious. Now, Anna found some interesting ways. She didn't do neurofeedback at all. She did guided meditations. And during her interview process, she would end up asking you to imagine, with your eyes closed, imagine the color red, fire engine red, flame red, blood red. Some color of red would kind of be your archetypal red. And she would see a flare in the EEG at a specific frequency, usually somewhere in the lower beta frequencies or higher alpha frequencies. And she was simply, in her notes, would red is here. And if and what happens is red, orange, yellow, green, blue, indigo, violet, the colors of the rainbow had specific frequencies order going down the spectrum. Now, during the meditation, if she sees, oh, well, your block for your energy movement is at this frequency, red, orange, yellow, green, green grass, green meadow, green eyes, somewhere in her guided meditation, green would suddenly pop up, and it would foster content at that frequency. So she would simply try and fill in the gaps, what she called goosenecks. Again, this would be bilateral. So where there was a gooseneck, a section where there was no energy being produced, she would end up having to fill that in with her guided meditation. She was a master of guided meditations, and her evaluations, the evaluation interview gave her tremendous insight into content that could evoke the state. The short answer is that unconscious, preconscious material is down here. And for you to get it up into adult access, you have to have it available. Now, in current neurofeedback world, alpha theta training. You train alpha so that you make good alpha, and then you train theta. During the theta, you have unconscious material that flows up from unconscious into more conscious, and you hold your alpha around instead of having your alpha disappear. Remember alpha dropout and then theta? Well, once you learn to hold your alpha, you have an adult awareness during the theta content. So unconscious material is processed with an adult awareness during the deeper state. So alpha theta training gives you access to deeper material. And quite honestly, a lot of people end up dredging up material that they didn't even expect. I had some trauma in the military, and you do alpha theta, and suddenly they're having images of attachment trauma early in their life.
You don't get to, what I've seen working with other practitioners and looking at the correlate EEGs and their experience, they don't get to titrate how much is going to come to the surface, right? And that can become a real problem for any practitioner that wants to do deep work that has to do with subconscious or trauma in general, right?
And they do recommend, if you're doing alpha theta work, that you end up having a team of people, a network already knit together to deal with any abreactive material that pops up. And there's actually a book called Alpha Theta Training in the 21st Century. It's in its second edition. And it's got lots and lots of therapists, including some that are Jungian deep analysts as well. And their discussions have their orientation in their chapter. I've got a chapter in there as well. I talk a little bit more about just the alpha training and dropping arousal level, getting slow alpha to be present, not just fast alpha. we found basically in things like alcoholism, where you don't really have much alpha, low voltage fast EEG is a classical alcoholic EEG. If you train alpha, usually by that point they're experienced enough to kind of feel like they're better. Whether you need to bring up abreactive material or not is another matter. But once you've trained alpha in an alcoholic who had none, usually they're out the door ready for experience on other levels in order to deal with other things.
Oh, go ahead.
Anyway, I don't mean to run you past your normal end time. I didn't schedule anybody afterwards in case you ran over. But
No, well, this is phenomenal. I can we invite you back? Can you come back?
oh, if I'm alive, I'll be happy to talk. You know what I mean? My wife said, just press start,
This is so useful. I think this will be such an amazing tool of understanding and insight for so many of our practitioners, specifically around the COVID. We didn't get to go into some of the post-vaccine reactions that sometimes mimic COVID.
Yeah. If you take an inoculation and you have what feels like a small cold, you actually have subtle inflammatory change, and you probably aren't going to get a cytokine storm level, but the slight inflammatory, you might have a headache. That's the ischemia. The injection can give you a mild inflammatory process, and that's enough to give you a brief brain fog. Usually it goes away. And people that have long COVID, quite often the injection of the vaccine ends up breaking off their COVID, their long hauler COVID, which was still locking on, probably an autoimmune issue. It gives them a spike protein to lock onto, and it gets them away from having an autoimmune related problem. And quite often the long COVID symptoms will go away after the vaccination. But the vaccination can give you the subtle inflammatory process that gives you a brief symptom.
Well, and that'll be something maybe worth exploring later on, because what we're seeing, as well as with some of the Johnson and Johnson and the AstraZeneca injections, is they're very, it seems like they're relating to ischemias, CVAs even. There seems to be a similar mechanism involved, and we're seeing a lot of clients coming back post vaccination with unexplained depression, unexplained brain fog. And they're showing up with brain maps that look kind of almost like long hauler.
Yeah.
Right. So it seems like maybe, and this is where reporting and, and this is all highly politicized, but yeah, I mean, it's, I think that there's still more to explore even on that end. So
try to post about this on Facebook sometime.
Oh boy, yes. If you want to stay busy for the next 5 years with responding to comments.
So, if you talk about vaccines causing a long hauler type symptom or something, you can expect the conversation to be pulled. They're awfully sensitive or oversensitive or something about it at this point. But we're in the midst of the pandemic, so it's I can understand some sensitivities. So
no, so it's good. So we'll have to we'll keep a comma on that one, and we can explore that again. But I would love to dive deeper into the subconscious and EEG, consciousness itself. Oh my gosh, Jay, describing some of the resonance between the glial cells and the cortex. I mean, there are things that are mind blowing.
I have specific topics on the models of how consciousness works, and I actually have publications on how healers can have a distant effect on somebody. That's actually published in an engineering journal. So
beautiful. Okay, so I'm going to officially invite you back, and I know that you've had health issues. I know we'll probably speak to it a little bit in some of the show notes, but if you're game and you're open to it, we'd love to have you back and explore this, because we have so many healers and practitioners and doctors, and however we identify, and we're here to help other human beings live a little bit of a fuller life. And I think that your insight and wisdom will be exceptionally helpful for all of us. So,
well, I'll do what I can to share what little bit of knowledge I might have. Wisdom comes really pricey, and that wisdom stuff is hard to come by. It's like the food pyramid. There's a lot of data, a little bit of knowledge, and almost no wisdom at the top. So.
Well, then we're going to take it where we can get it. I know we know where to find it, and we know that you've got a lot of it. So I appreciate it, and we'll dive deeper because I'd love to explore that.
Sounds like fun to me. So.
Thank you as always. Thank you for sharing your time.
Bye-bye. Thanks for the invite.
Bye-bye. Thank you again.